Hello, everyone. The International Headache Society just published a statement that changes how we should think about migraine prevention. The main message is start preventive treatment earlier in the disease course. So basically, before migraine becomes chronic and treatment resistant. So let me break this down and let me explain why this is important and why it matters. First, let's go over some numbers. Migraine affects 15% of people globally. Chronic migraine, so that's 15 or more headache days per month, with at least 8 of those having migraine features, affects 1 to 2% of the population. And each year, about 3% of people with episodic migraine progress to chronic migraine. But progression isn't just about frequency. When migraine progresses, you see something called medication overuse, or also called medication adaptation headache, and that's when the acute medications themselves become part of the problem. You also see treatment resistance. Therapies that worked before, they stop working. And you also see refractory migraine. So that's when all available treatments fail, or all available current treatments fail. So it's problematic. You also get psychiatric comorbidities. So you get depression and anxiety, and that becomes even more common as migraine progresses. You also have increased disability, work and social functioning decline. Right now, most people don't get preventive treatment until they're already having 8, 10, or 15 migraine days a month. By that point, the disease has often become complicated. We're essentially waiting until people are severely disabled before we intervene. This isn't done with any other disease. So let's talk about what happens to the brain to just really reinforce what's going on here. Brain imaging studies show physical changes in people with chronic migraine, structural changes. We see gray matter thickness alterations in cortical areas. We see iron deposits in periaqueductal gray matter and red nucleus. We see impaired lymphatic system function. So that's the brain's waste clearance system. We see functional changes as well. We see altered connectivity between brain regions. We see changes in how the cortex processes information. We have abnormal resting state activity patterns. We find elevated CGRP, that's calcitonin gene-related peptide. So that's a molecule that is implicated in migraine pathophysiology and which we have treatments for. We see neurochemical changes in brain regions involved in pain processing. So we see all these changes, and the problem is that some of these changes may not be fully reversible. The iron deposits, for instance, they don't just go away. Higher iron levels in certain brain areas are linked to poorer responses to both Botox and Erenumab, which is another anti-CGRP medication. We don't know yet if all these changes are consequences of having migraine or if some people have brain traits that make them more susceptible. But either way, treating before these changes accumulate makes sense. The data supports early intervention, and this comes from multiple sources. The Appraise trial, it tested Erenumab, again, we mentioned it, an anti-CGRP receptor antibody, it's a monoclonal antibody, and people who weren't resistant to previous treatments and had fewer monthly migraine days at baseline responded better to the medication. Also, the Eureka Consortium study, it analyzed over 5,800 patients across Europe. They found that people with fewer monthly migraine days were more likely to be 50% responders to anti-CGRP monoclonal antibodies. Onabotulinum toxin A, that's Botox, research showed that starting treatment within 12 months of chronic migraine diagnosis led to better outcomes compared to starting later. Central sensitization studies found that people with established central sensitization, that's a pain amplification process in the nervous system, they responded worse to anti-CGRP therapy. Early treatment may prevent central sensitization from developing. That's huge. Allodynia, for example, one of the symptoms of central sensitization is a huge problem in the migraine community. This mirrors what we've learned in other neurological diseases. In stroke, early thrombolysis or thrombectomy saves brain tissue. In multiple sclerosis, early disease-modifying therapies prevent disability progression. In epilepsy, starting anti-seizure drugs after a first seizure reduces recurrence risk. Even in Alzheimer's, the new anti-amyloid antibodies work best in the early stage disease. So we see this across various and vast neurological diseases, but for some reason when it comes to migraine, that's when we stop and wait for the migraine to progress. It's nonsensical. So the International Headache Society's recommendation is start effective and tolerable preventive treatment at 2 to 4 monthly migraine days. Not 8, not 15, at 2 to 4 days per month. And so why this threshold? Well, current guidelines they support it. However, it's rarely implemented in private practice. It's very unfortunate. The recommendation aligns with existing European Headache Federation and European Academy of Neurology consensus statements. So what qualifies as an effective and tolerable treatment? Any preventive therapy with proven efficacy and acceptable side effects. And so we already know what these are. We have the anti-CGRP monoclonal antibodies. We have the CGRP receptor antagonists. Those are your GPANs, for instance. We have your traditional preventives that patient can tolerate. So certain beta blockers, anti-epileptics, antidepressants. We have onabotulinum toxin, Botox, for chronic migraine. There are non-pharmacological approaches that can be used also when appropriate. There are many things that we can do for prevention. The issue is starting them. So we want to move from attack prevention to disease progression prevention. You could think of it as a subset of prevention, but also vastly important. Start early, hit it hard. The International Headache Society is calling for 2 actions in clinical practice. Consider preventive treatment starting at 2 to 4 monthly migraine days using effective and tolerable therapies. However, 2, in research, conduct longitudinal studies to determine if early prevention actually modifies disease course and to identify biomarkers that predict who needs these early interventions. This approach won't work everywhere yet. Many regions don't have access to newer therapies, but the principle still applies. We have the same brains regardless of where we live in this world. Early preventive strategies, whether taking anti-CGRP drugs or other effective treatments, beta blockers, Topamax, whatever it may be, should be the standard of care. The goal is prevent the transition to chronic refractory migraine. We want to preserve brain health, improve long-term outcomes. So if you're having 2 to 4 migraine days a month, talk to your doctor about prevention. Do not wait until you're disabled. Thank you.